Chapter 15 covers taping and bracing. You're an athletic trainer? Oh yeah, the person who tapes ankles. Insert deep breath and eye roll here. Oh well, it's true. The application of adhesive tape is often the image that comes to mind when people think of athletic training. It is really too bad. Not that there is anything wrong with the prudent application of athletic tape. This chapter is dedicated to the topic. The reality is, applying taping techniques makes up only a small portion of the athletic trainer's professional duties. Certified athletic trainers spend much more professional time on things like injury assessment, initial care and management, and rehabilitation. Historically, the efficacy of some taping techniques under specific conditions have been questioned in the literature. While some techniques have shown to be useful, a large number remain untested and rely solely on clinical observation or anecdotal evidence for their use. Despite some of the uncertainties, there are enough well-supported uses of taping, bandaging, and bracing that they should be considered foundational skills for the athletic training student. Adhesive taping in an athletic training setting has many uses, including securing dressings and compressive wraps, providing preventative support for joints during activities, supplying support following injury, and securing protective padding. The goal of any preventative technique, such as ankle taping, is to limit the motion of the body part by applying the taping technique. Taping skills are readily identified within the practice domain of the athletic trainer. However, very few taping skills have been subjected to the rigors of clinical trials research in evaluation of their efficacy. Most have been developed and their efficacy described by anecdotal evidence, most often by an athletic trainer observation and patient feedback. A recent review of clinical trials examining functional treatment strategies for acute lateral ankle injuries in adults is useful when looking at the tape versus brace issue. This clinical trial only looked at data from randomized clinical trials that included functional treatment strategies such as bracing, taping, and using elastic bandages. Of the numerous studies examined, only 9 met the criteria for inclusion. These 9 represent 892 participants and examined outcomes such as return to sport, return to work, pain, swelling, objective instability, subjective instability, range of motion, and satisfaction. Some of the findings include the following. Tape versus elastic bandages research. In early stages of injury, the use of tape was not supported. The use of an elastic bandage will lead to fewer complications to the skin. No significant difference was noted in any other outcome. Tape versus a semi-rigid ankle support. No significant differences were found in any of the outcomes between taping and the use of a semi-rigid ankle support. Tape versus lace-up ankle braces. No significant differences were found on any of the outcomes between these except for less swelling at short-term follow-up when using a lace-up ankle brace. Many studies have looked at taping versus bracing under a range of conditions to better assess the protective quality. A 2000 review paper exploring the effect of protective measures on the incidence of ankle sprains identified some pertinent findings. The use of tape or braces may result in less severe ankle sprains. However, braces seem to be more effective in preventing ankle sprains than tape. The efficacy of shoes in preventing ankle sprains is unclear. Proprioceptive training reduces the incidence of ankle sprains in athletes with recurrent ankle sprains. It is noteworthy that the overwhelming majority of the taping versus bracing discussion focuses on the ankle. It is clear that more research is needed to examine the efficacy of many other taping techniques. In the meantime, we can safely say the following. The cost, benefit, and ease of use may make ankle braces a better alternative to taping. Taping efficacy is dependent upon the skill of the practitioner and the desired time needed for protection to the ankle, similar to a brace, but not for as long of a period of time. As time passes after application, the efficacy of taping becomes limited. Athletes' concerns about decrease in performance from taping or bracing does not appear to be valid. A wide variety of athletic tapes are available for use by athletic trainers. Non-elastic white cotton cloth athletic tape is the most common tape used to provide support and secure bandages. This tape is available in 1/2, 1, 1.5, and 2-inch widths of various quality grades. Application of non-elastic tape requires instruction followed by practice because it does not easily conform to the body. Knowing the angles to get the tape to go where you want it to is a learned skill. This tape is also constrictive. If it is applied improperly, it can cut off the circulation and damage the surrounding tissue. Elastic tape easily conforms to body parts, making it a good choice for a range of tasks. Elastic tapes come in varying strengths and are often used in combination with non-elastic tapes to provide additional support. Elastic tapes are available in 1, 2, 3, and 4-inch widths. Other essential taping supplies includes underwrap, heel and lace pads, spray adherents, and protective ointment or lubricant. Underwrap is an ultra-thin foam-like product that can provide protection over superficial bony areas and prominent tendons. A spray adherent can aid in improving the adhesion of tape and compressive wraps. Additional supplies needed for safe and effective taping include a razor for hair removal, tape scissors for cutting tape, and tape cutters for tape removal. The following precautions should be considered when applying tape to a patient. Make sure there are no underlying skin irritations or skin conditions that would prevent the safe use of a spray adherent or adhesive tape. Avoid cutting off circulation to the extremity. Smooth application free of wrinkles will prevent blisters and cuts. Avoid using non-elastic tape around a muscle. When using underwrap, make sure that you anchor the tape to the skin using a large enough area to avoid skin irritations. Taping of an acute injury for the purpose of returning to play is largely contraindicated. The following slides go over several common taping techniques that athletic training students should become proficient in during their academic career. Prior to taping a patient or athlete, there are a number of things to consider, such as being sensitive to patient position, using anchors to secure above and below the joint you are stabilizing, always overlap tape by half to maximize strength and avoid gaps in the tape, do not tape continuously with non-elastic tape which can constrict the extremity and disrupt circulation. Avoid wrinkles and gaps in the tape by smoothing the tape as you apply it. Ensure that the skin is clean, dry, and healthy prior to taping, and taping to the skin for maximum support. Longitudinal arch taping is used to support the longitudinal arch of the foot under a variety of conditions. The taping can be used to support the arch as part of the treatment program or return to play activity for a sprain injury. Taping the longitudinal arch is commonplace as an adjunct to plantar fasciitis treatment and is also frequently used to assist with treatment of common lower leg injuries such as medial tibial stress syndrome and posterior tibialis tendinitis. Turf toe is an injury to the first metatarsal phalangeal or MP joint. It is named due to the common occurrence on hard artificial surfaces. The injury involves pain, swelling, and irritation to the first MP joint, secondary to excessive hyperextension of the great toe. The purpose of turf toe taping is to support the first MP joint and prevent excessive hyperextension. The purpose of the preventative ankle taping is to provide support from the common inversion ankle sprain injury. The efficacy of this taping will be dependent upon several factors, including how the tape is anchored, the time between application and the activity, and the previous injury history of the patient. The use of preventative taping has been explored in the literature mostly as it is compared to ankle bracing. Despite some of the advantages that bracing may provide, taping of the ankle is still commonplace due to athlete preference and the common use of variations to this procedure following injury. Note, there are countless variations of this preventative ankle tape job. The example provided is one variation on the basket weave taping technique. Students will see many variations among the professionals they encounter. The Achilles tendon taping helps limit dorsiflexion of the ankle. By limiting dorsiflexion, pressure can be alleviated from a strained or inflamed Achilles tendon. Chronic Achilles tendon irritations can be particularly difficult to manage. While taping support is helpful, it is not a replacement for appropriate rest and therapeutic treatment. Taping of the knee is not a common practice for the athletic trainer. As a rule, the use of knee braces coupled with the ineffectiveness of most tape jobs to this joint have made taping of the knee almost obsolete. There are two exceptions to this rule. Taping of the patella to affect patellar tracking, which is described in the box on page 324, and taping of the medial collateral ligament or MCL. The MCL protects the knee from valgus forces or force on the lateral side of the knee and also assists in preventing anterior movement of the tibia on the femur. The elbow taping is designed to prevent hyperextension of the elbow. Forced hyperextension can result in a soft tissue injury to the anterior anatomical structures of the elbow joint. Severe hyperextension can result in bony injury to the ulna or humerus. More severe forced hyperextension may cause an anterior dislocation, a rare event. The hyperextension taping is often used to protect the patient as he or she returns to activity. This taping must be anchored to the skin to be effective. The wrist taping is used to provide general support to the gliding articulations of the wrist. The wrist taping can also be used to limit either flexion or extension based on the use of check rein style strips that cross the wrist joint and attach to an anchor that is secured around the hand. Sprains to the thumb frequently involve hyperextension of the metacarpal phalangeal or MCP joint and may involve a valgus force that injures the ulnar collateral ligament or UCL of the thumb. A complete rupture of the UCL will require anatomical restitution through a surgical repair. The taping of the thumb will vary depending on the severity of the injury and the activity of the patient. The greater the fine motor movements needed, the more difficult to tape the thumb securely. Fingers most often taped to provide support to the adjacent finger following a sprain to the proximal interphalangeal or PIP joint. This taping style is known as buddy taping. This taping can use the adjacent finger as a splint while still allowing flexion and extension. Athletes who must wear removable gloves for their sport activity will need to have the finger taped around the specific joint. This can be accomplished by using strong elastic tape that wraps around the finger and is held in place by non-elastic tape. Careful removal of all tape and adhesive residue following use is essential for skin health. After a practice or competition, athletes should remove their taping using surgical scissors with a safety edge or a commercial tape cutter. Care should be taken to use scissors or tape cutters in such a way to avoid bony prominences. A small drop of lubricant will help glide the tape cutter. Care should be taken when removing the tape from the skin. Tape remover products may be helpful. Upon removal of the tape, athletes should carefully wash the areas as to remove all adhesive residue. Athletic trainers who are taping athletes on a regular basis can inspect for evidence of skin irritation before applying tape. Persistent skin irritation may require trying alternate tapes, different adhesive, or in some cases, referral to the physician of a consultation on specific rashes. The use of elastic bandages and compression wraps is common in many sports medicine settings. Elastic bandages are used to apply an even amount of compression to help reduce swelling and to provide support to muscle tissues. They are used post-injury as supporting devices and are not strong enough to offer any significant level of protection to anatomical structures. However, when properly applied, they are invaluable in assisting the recovery process post-injury. Elastic bandages come in a variety of widths and lengths that allow the athletic trainer to make an appropriate selection based on the desired body part being treated. When applying an elastic wrap for compression, specific guidelines must be followed. Choose proper width and length for the body part being wrapped. Apply from distal to proximal to best combat gravity and assist with the reduction of edema. Overlap by 1/2 and apply in a circular fashion. Apply with modest tension to avoid constricting circulation. Check the circulation in the extremities often to ensure the wrap has not been applied too tightly. Do not allow the patient to sleep in a tight elastic wrap because compression may be too tight in a relaxed state. And a compression pad, such as a horseshoe, foam, or felt pad, may also be used to assist with compression. The spica pattern is a figure 8 pattern commonly used with a variety of elastic bandages. When applying the spica pattern, one loop of the figure 8 is smaller than the other based on the involved body part. It can be used to support muscle injuries in conjunction with protective padding and to hold ice bags in place. The two most common areas to use the spica pattern to help support the muscle are the groin and hip flexor. The application of this technique can allow patients to ambulate with greater comfort to support the injured muscle, as well as to apply compression to a newly injured soft tissue as part of the Price treatment post-acute injury. A variety of braces and supports are available for use in the sports medicine setting. To discuss them all is outside the scope of this introductory text. However, ankle braces and knee braces seem to garner the most attention. The use of a lace-up or a rigid ankle support can be an effective tool in prevention of injury and is also useful for providing support during the return to activity phase of a rehabilitation program. When properly applied, ankle braces can, over time, be a lower-cost alternative to preventative taping. Knee braces can take on many varieties. The postoperative hinge knee brace is commonly used to assist with ambulation following a surgical procedure. Many braces are available to help patients prevent knee injuries and to protect specific structures during sport activity and rehabilitation. These braces are known as functional knee braces. In addition, there are countless neoprene sleeves and supports designed to provide warmth, compression, and modest support to the knee joint. Some neoprene sleeves are specifically designed to support the patella. Open holes and lateral buttresses are built into the sleeve to help control patellar tracking. The techniques presented in this chapter are designed to give students an overview of common methods and to establish foundation for supervised development of skills. The use of taping and bracing in sports medicine needs further study to fully evaluate the efficacy of specific techniques and allow for greater reliance on evidence-based practice. Great care must be taken in the selection of the taping materials and the application of the techniques in the interest of patient comfort and safety. Students should strive to master these foundational skills because they can be a source of great confidence and allow for initial patient interactions for an athletic training environment.